Our next part of the discussion this afternoon will be pivoting to talking a little bit about those subject matter experts in the ED and talking about the role of the ED in managing preeclampsia. So we're going to do this as a roundtable, and obviously it's not very fun when we're not in person, but we're going to try to do our best in the virtual environment. So we have 5 speakers representing different realms of the ED, and I'll introduce each of them. Their full bios, again, are online, and please feel free to look at those in detail, but for brevity, I'll just give a brief introduction to each speaker today. Ms. Amber Porkinish is the Administrative Director for Perinatal Services at Children's Hospital of San Antonio. In that role, Amber oversees a 60-bed level 4 NICU as well as Women's Services Department. Prior to joining Christus in 2014, Amber retired from the Army Nurse Corps. Our next speaker is Benita Patel. Dr. Patel is an Associate Professor of Pediatrics at the Baylor College of Medicine. She serves as Chief Quality Officer for Medicine at Texas Children's Hospital and Associate Division Chief for Clinical Operations and Quality for the Division of Pediatric Emergency Medicine. Her publications are vast, and related to our discussion today are those works improving timeliness and efficiency in the emergency center. Our next speaker is Dr. Samuel Pratter. Dr. Pratter is Associate Professor and Executive Vice Chair of Clinical Affairs in the Department of Emergency Medicine at McGovern Medical School at UT Health in Houston. In that role, Dr. Pratter oversees clinical operations at 5 emergency centers in Greater Houston area. And additionally, Dr. Pratter serves as Medical Director for Emergency Services at Memorial Hermann Texas Medical Center. Our next speaker is Dr. Sarah Robbie. She's a board-certified emergency medicine physician and serves as Assistant Medical Director at the Ben Taub Emergency Center and Assistant Program Director for the Emergency Medicine Residency at Baylor College of Medicine. She completed medical school and residency at Baylor College of Medicine with subsequent completion of administrative fellowship at Ben Taub. As recognition for her leadership, she was recently awarded the Early Career Faculty Development for Excellence in Patient Care Award. And last, we have Ms. Denise Brown. She is a nurse ER coordinator at Guadalupe Regional Medical Center, a level 2 facility in Seguin, Texas. In that role, she assists the emergency department director in management of the unit and monitoring all aspects of patient care. Ms. Brown was a Daisy Award winner in 2016. Welcome all. So I thought to kind of go to around the aims for this project, we would kind of talk through what is the current state of affairs in the ED. So I'd like to kind of propose this to all the speakers, and I'll call on each of you individually. For patients, when they come to the ED at your facility, and recognizing your facilities are different, some are pediatric EDs, some are level 2 facilities, some are level 4 facilities. So if a patient comes into the ED at your facility, do you have a formal process for screening whether a patient is pregnant or recently pregnant when they come in, and what does that screening look like if you do have it? And I'm going to start with Dr. Robbie.
Hey guys, can you hear me? Hopefully, yeah. Okay, perfect. So we don't have a standard screening right now. It's actually one of the things we're looking at because there are so many screenings currently in our emergency department that the triage nurses do. In the lecture before, they talked about how nurses are key in terms of implementing screenings like this. So it's actually a project we're working on with our accreditation folks, because currently the nurses do, like, just off the top of my head, trauma screening, suicide screening, fall screening, COVID screening, travel screening, you name it. And so triage, which is supposed to be a very quick, like, sick, not sick process, has turned into this almost like 20-minute like evaluation. And when you're a level 1 trauma center, stroke center, right, county hospital with increased volumes, it becomes it becomes a little difficult in terms of trying to incorporate all that in, but being efficient as well and treating the emergencies. So we're actually looking at consolidating all of those screenings into one and maybe adding some screening for pregnancy. One of the epic fixes that we did find in the interim is that we have added a pregnancy icon to our EC track board. So when you look at the track board for all the EC patients, it's very easy. There's an icon that pops up next to that looks like a little baby. That shows up for any patients who've had a positive pregnancy test in our system or a positive quant within the past 14 weeks. So, it's not perfect because there's limitations, right? Because it still include patients with normal pregnancy, recently postpartum, non-viable IUPs, ectopics, like gestational trophoblastic disease, germ cell tumors, but it is something we have been able to work with informatics on right now to have at least some way to target some of these patients and identify them quickly in the ED.
Great. And I'll get to the other speakers in a second, but just about that Epic icon, because we have the same thing. What happens when the patient delivers? Does that icon go away at your facility?
No, so that's what I'm saying. So if they're postpartum within 14 weeks, it actually doesn't go away, and that's where one of the limitations I just mentioned comes in with it.
That's great. Dr. Pratter.
Yeah, I would echo a lot of what Sarah said. There's a lot of pressures on triage, right? Certainly at Memorial Hermann, the Med Center. It's there in the triage form, right, for nurses to go through whether or not the patients are pregnant or recently pregnant, right, what their last menstrual period is, right, if they fill that out, what automatically calculate what their, right, estimated gestational age is. But, there are a lot of pressures on triage, so whether or not they actually complete the entire screen, that's a different story. Just like Sarah said, with, at our other hospital at LBJ, we also have the same, pregnancy icon, because LBJ and Ben Taub are sort of under the same healthcare umbrella at Harris Health. And then I'm sure Sarah's doing the same thing, but we have providers up in triage at LBJ, and we're adding screening ultrasounds as part of their initial triage assessment as well.
Great, thank you very much. Dr. Patel, you're at a pediatric facility that you're running the ED there, and I'm sure you have a different approach to this. Could you talk through what that looks like at your facility? Yep, you're muted. Yep. Can somebody? I'm going to skip over you for just a second, Dr. Patel. Amber Cornish, do you want to tell us about your facility?
Sure. So I am actually with Chris's Health right now. I'm with the Children's Hospital of San Antonio, and of course, it's fairly obvious when an adult patient comes in that they're either pregnant or they're postpartum. But we still do ask, and we do have the adolescent patients that present both while pregnant and postpartum as well. I am counting the days until we get a new electronic medical record. We are actually getting Epic in 2023, but right now we don't have anything that signifies a pregnant or postpartum patient. Again, just asking the questions amongst all the triage questions has been a challenge. I know in our adult facilities as well. We have now got it hardwired only because we've worked really hard with our teams in both OB and ED to get that to be part of their workflow.
Great, thank you very much. Oh, we lost Dr. Patel. We'll go to Ms. Brown and we'll come back to Dr. Patel in a second.
Yes, we do have two questions in our triage. One of them that just simply asks if the patient is pregnant, and another one that asks if they've delivered within 30 days. But as the other panelists mentioned, I can't say that it's done consistently. When triage isn't backed up, maybe so. But when it's crazy, I'm pretty sure it's not consistent.
Dr. Patel, are you back? We're getting her audio fixed. So I think the icon is a great idea embedded in your EHR. I guess the challenge becomes, what if the patient is from a different facility, i.e. across the street, and they present? How would you know if they were pregnant or not, or to be astute to that? Can you guys comment on what that looks like, or how you would approach that?
So typically the patients, the biggest population we see, at least at Ben Taub, and this might be the same at LBJ, I would assume, is that Legacy Clinic is a huge clinic in Houston that takes care of a lot of patients who don't have access to healthcare afterwards. And we see a lot of their patients in our emergency department with complications during pregnancy or postpartum. And so most times those patients come in, saying that, hey, the clinic sent me over for this. So you already are kind of prompted in that sense to know. But if not, we have providers in triage 24/7. It's something we started a few years ago, where after their triage is complete, even if the ER is backed up and there's no beds, you actually have either a physician or APP, or sometimes both if the volumes are high enough, that are seeing patients in the waiting room as they come in to get their story and kind of prompt them up and kind of figure out what they need to get done. And that's usually where we figure it out in those cases, that, oh, you're pregnant, you came from here, what's going on with you, and ordering what we need to do to evaluate for that.
Thank you. Dr. Patel, you're back? No, not yet. No, sorry. Anybody else have a comment about the patients coming from a different facility to your unit and how you would potentially identify them if they didn't speak up and inform the team?
It's just like Sarah said, I mean, that we have the expectation is there, right? And it all depends on triage pressures and what they can do. I think fortunately most of the emergency departments in this, at least in the Houston area, do have providers in triage. Certainly all of ours do as well. And so there's always a second layer of a second triage that happens where, depending on the patient's complaint, whether if triage didn't think to ask it, a different provider may think to ask it, and we have across the Memorial Hermann system, triage protocol labs. So a lot of these patients get protocol labs from triage. And if it's a female who's presenting with abdominal pain, right, you can't get a lab without getting a pregnancy test on that patient. So there's no ability for the triage nurse to uncheck the pregnancy test. So that would be automatically sent as well.
Okay. So my next question for the group is, so you heard kind of what the project plan for the OB committee is. From your specific units, what do you see as challenges to implement that in your specific area? And I'll go backwards. I'll start with Amber Cornish.
So I feel like, we're starting from the beginning. And so there's not been a lot done between the areas of OB and the emergency department. So I think the biggest challenge is just reaching out to pediatric providers and talking about preeclampsia and pregnant moms presenting and all the treatment for that. I can tell you from my experience of having done this with an adult facility, the biggest thing is awareness. We had an unfortunate event. We had an eclamptic mom come in and we used that as our teaching moment. We did a debrief and then we did simulations with them and education from that. And that really is the way to go. I know the speakers spoke of that. And I think that that's huge to actually walk through the scenario, let them know what the symptoms would be or what they would even present like, and to go from there. But I think the greatest challenge, though, is just the time to do it. Our ERs are so overloaded right now, and often there's holds, and it's the last thing people want to do is simulate. But I think it's important, and we just have to help them see why it's so important that we need to utilize that time for that.
Yeah, for sure. And we heard that from Dr. Pratter and Dr. Robbie, that this overload with all the screening tests that are done. From your truth's perspective, what do you see as any opportunities that we could do with this project to help streamline, to make it more easily integrated into your units? I'll start with Sam.
Yeah, I think Sarah's kind of hinted at this a little bit, because it sounds like they're undergoing a project where they're trying to sort of recategorize the priorities for what's going to be screened in triage versus what's going to be screened at the back end at the bedside by the bedside nurse, and so I think, just being involved in those conversations and being involved in developing those processes and making sure that, something like as critical as pregnancy status and a last menstrual period, if a patient is pregnant, really does need to remain at the front. And then other things, fall risk and things like that, can be pushed to the back end and can potentially be completed by the bedside nurse instead of the triage nurse.
Sarah, do you have any other comments?
Yeah, I would totally agree with that. I think, and this is where one of the challenges is getting all the stakeholders together, because this is a really busy time, I think, for hospital systems in general. The past 2 years has been a busy time for anybody working in healthcare. And so because what we realized very quickly was when we wanted to change things on our checklist, you had to get accreditation folks involved, and what affected one hospital affected another hospital. And then there was other maybe certifications or accreditations at risk. So I think kind of getting all the stakeholders together, even at a higher level above the emergency department and OB, is key, and kind of explaining to them, this is actually really important and something we need to capture earlier rather than later.
Great, thank you. Denise, how about your perspective?
I agree. I think like a multidisciplinary approach to reprioritizing the screening and triage is extremely important. I think that would help make an impact.
And I think Dr. Patel is still not back on yet.
I think I'm back.
Oh, yeah, we can hear you now. Good. Yeah.
All
I can't see you,
right.
but I hear you.
I think from I'll go a couple of questions back from a pediatric ER perspective. That's we've got 3 different hospitals, 2 out in the community and 1 right in the medical center that is connected to our pavilion for women. So we do get challenges. It's going to be still rare for a postpartum patient to walk into our emergency center, or even a child, a 15-year-old, 12-year-old, 15-year-old to come in. I don't think that it's routine screening for pregnancy or postpartum in pediatric ERs. Many have adopted, similar to what Sarah and Sam have stated. There's so many screenings that we do up front that it is not universally adopted yet for our ERs. It's also not at the top of our differentials when we deal with 15, 16-year-old. Likelihood of other contributors to hypertension is going to be there. So I think that's a challenge for us. I think that there would be great utility in trying to find a way to help with the recognition piece of it, especially for the pediatric ERs, and then truly trying to come up with a way to escalate and rapidly get them to the right place or get consultation with our OB partners.
Great, thank you very much. And on that note, that leads me to the next question I was going to ask the group, and it probably looks different at each of your facilities as well. Do you have, on your units, do you have some formal criteria or process for your unit for consulting OB providers when a patient who's in the postpartum period presents? And I'll start with Dr. Patel, and we'll kind of go through the list.
So for us, because we do we've set criteria for what is seen in our emergency center versus those that we send to a facility that does have OB, and we've set that at 14 weeks. And then for postpartum, it's within 6 weeks postpartum. We try to get them to our pavilion or to this an adult facility. We can call our colleagues in our pavilion by phone, and at one of the community sites, we've tried to set up a telehealth system so that they can call the on-call person.
Great, thank you very much. And let's, how about Ms. Brown?
We don't really have a formal process. The providers typically, if they're hypertensive or bleeding or febrile, they will just contact either the patient's obstetrician that they had or whoever's on call.
Okay, Ms. McCormick? Amber?
Sorry. Yes, we have guidelines in place. So in one of our facilities, it's 20 weeks and above. We'll go straight to labor and delivery. At the Children's Hospital, though, it's any pregnancy test will go up to our OB-ED. So that's just been newly adopted. We're trying it out, but because of the we have the fact that we have OB hospitalists in the hospital at 24/7. That's what we've decided to do. Again, it's important to have the stakeholders at the table to discuss what would work best in your facility.
Sure. Dr. Pratter, oh, he's busy.
Yeah. So we're also lucky at Memorial Hermann the Med Center because there's a separate obstetric emergency department, and so anybody who's over 20 weeks would go up there or out all the way out to 6 weeks postpartum would actually go upstairs. We will keep them downstairs if they're unstable for any reason. So, altered mental status with elevated blood pressure, right, a pre-hospital seizure, anything like that, that patient wouldn't ride in an elevator. They would just go right directly into a resuscitation room. And we keep one of our trauma resuscitation rooms open for precipitous deliveries and these kind of obstetric emergencies. So we would automatically have the OB team actually come downstairs instead, and then together we would take care of the patient.
Good, thank you. Dr. Robbie?
Yeah, so for us, we also have an OBI or OB intake that takes patients over 14 weeks pregnant for any complaint that they come in with. The exception to that is if they're unstable, then they stay in the EC, and of course we will manage them in the EC acutely, and we'll call OB down to come and see them. Typically with postpartum, since we don't have a good screening tool, it's something we educate the triage nurses on. So if the blood pressures are a little bit higher, like greater than 140 over 90, and they have headache or they have vision changes or things like that, typically if the triage nurse catches it, they send them straight to OBI, and we actually have a process in Epic where you can transfer transfer the patient from EC to OBI in Epic, because that was one of the challenges with that. In general, I would say that OB at our hospital is pretty great, and they will come and consult on any postpartum patients we have that we may have questions on. So even though we don't have set categories, they're very responsive anytime we have a question with anything going on with those patients. The other thing I would say too, since we're talking about kind of the postpartum patients coming into the emergency department, is to advocate for them getting lactation services and involve them earlier on. It's not something we think about, right? Because we're emergency medicine physicians and we're worried about the emergency that's going on. But now, having had 3 kids myself and having to go into an ER when I was breastfeeding, we have manual pumps in the EC, but like your lactation services in your hospital, getting them involved, they can bring electronic pumps, they can help offer, any sort of support to your patients who are there. Just something else I wanted to add in as well in terms of postpartum care.
Great comment. And I think certainly as we branch out and make this initiative throughout the state, we have a very large number of level 1s and 2 maternal facilities in the state. And we have a group of people here that are probably more resourced centers where they have the luxury of having an OB triage potentially, but that'll be something that we'll definitely have to explore as we work with the lower level facilities. What does that look like there as we move this initiative out? And kind of there was a comment in the chat box, it just disappeared, but it gets into the therapy, and that was related to my next question. So in the current state in your units, for an otherwise healthy, non-pregnant patient who comes in with no comorbidities, are there like general criteria that you guys would treat hypertension in a otherwise healthy patient for like a hypertensive emergency? And then if they're pregnant, do you adapt that therapy based on your guidelines? And when I start with Sarah, and we'll go backwards.
Yeah, so I think it's important because we hear, the term hypertensive emergency and hypertensive urgency a lot. And hypertensive urgency is a term that's really fallen out of favor in the emergency medicine world, but it's something that, and Sam can probably comment on this, but we still see it being used as a term by other folks who may be sending patients into the emergency department. So what we really think about is hypertensive emergency, which is a crisis in which there's evidence of acute organ damage, right? And I'm talking about like the non-pregnant patient that comes in. And so those cases, when they have end organ damage, they're encephalopathic, they have a heart attack going on, they're having pulmonary edema, a stroke, a dissection, like those require very acute management and hospitalization and often ICU management. Our college, the American College of Emergency Physicians, has developed a guideline for this exact thing because it's a lot of what we see, and it's for patients who are non-pregnant without signs and symptoms. And when they don't have signs and symptoms, it actually says that for asymptomatic elevated blood pressure, routine screening for acute target organ injury, like a creatinine or a UA or EKG, is actually not required. There are select patient populations that are exceptions. So we see this in our county hospital. So if they have poor follow-up, then you should be screening them for those things. And then if their blood pressure is elevated, you don't necessarily have to treat it. In fact, you shouldn't treat it too fast because that can be dangerous for them, and you don't want to drop it too fast. And it says that if you decide to lower their blood pressure, do it gradually, and don't expect it to get to normalized levels within the ED visit.
Sure. So for a pregnant woman that comes into your unit today, obstetric services aren't available. How would they be managed?
So pregnancy is different, right? I think because in pregnancy, you're thinking about more like preeclampsia, eclampsia. And so those are definitely, we have mechanisms to keep those. We have meds in the ED. We're lucky we have OB, so we can always consult them. And it's a matter of figuring out, like, is this a chronic hypertensive, right? Who's earlier on in their pregnancy, or is this something new that's going on during pregnancy where we're more worried about preeclampsia?
Gotcha.
Yeah.
Sam, go ahead, Sam.
No, in the guideline that Sarah mentioned specifically excludes pregnancy. It's not applicable to the pregnant population. So we treat pregnant patients with a blood pressure of 150 very different than we treat a non-pregnant patient with a blood pressure of 190, right? And I agree with everything that Sarah said. Asymptomatic hypertension does not need to be treated in the emergency department, and if you are going to treat it, you should give something oral. Right, and definitely don't give anything IV, right? Because we've actually seen the opposite, right? Through our quality improvement program, is we've actually seen patients, right? We've seen strokes precipitated in patients, right, who were asymptomatic hypertension. We were artificially treating their blood pressure just to hit a certain number, right, to make a nursing unit feel comfortable or whatever it was, right, so that they could get admitted upstairs.
So I'm just curious. I'm glad you guys mentioned the ER group is creating some guidelines. does the conversation about pregnancy-related management or postpartum management come up when patients maybe come into an ED, that the freestanding EDs especially, that don't have a direct connectivity to obstetric units? Have you guys, your organizations, talked through that or no?
Can you clarify your question a little bit,
Oh,
Patrick?
so your national organizations created guidelines for managing asymptomatic hypertensive patients. Have they dipped their toe into the water for pregnant patients? As far as like the freestanding EDs are managed separate from obstetric units, and I was just wondering if there's any guidelines that they've.
No, there's not. There hasn't been an ASEP. It's more of a policy statement, to be honest, than a guideline. But there is not an ASEP guideline or a policy statement on how pregnant patients should be managed with their blood pressure. I think at that point, ASEP would expect that the standard of care would be applied to those patients, right? And I think all of us on this call, and all of us who are practicing emergency medicine today, who've at least graduated from residency in the last 20 years, understand that the standard of care, right, for a patient who's either postpartum all the way up to 6 weeks, right, or is in their third trimester with elevated blood pressure, meaning blood pressure over 140 over 90, right, that patient should be, screened for preeclampsia, screened for help, right? If they are having elevated blood pressure, we should be initiating things like labetalol and hydralazine, right? Magnesium early, those kind of things. For freestanding emergency departments, if they don't have access to an obstetrician, and most of them don't, but many of them are part of a system of care, right? So the Memorial-Hermann system, right? The CHI, Methodist, HCA, all these kind of systems do have freestanding emergency departments, sort of as that spoken hub model, right? And they can certainly transfer their patients to the mothership, right, for patients who are having obstetric complications related to elevated blood pressure.
Great, thank you. Amber, do you want to comment to your facility for?
We're spoiled. We have OB and they are very quick to consult us. I will say at freestanding, we do receive quite a few patients though that come from freestanding centers that are referred to us for our OB services if they've presented with such symptoms.
Yeah, I think that is because the collaborative is generally focused on hospital-based practices. That is an opportunity in the future to kind of branch out beyond the hospital facilities to the freestanding EDs. Denise, do you want to comment for your facility?
I actually just so happen to have my ER medical director in the office with me, so I'm going to let him answer this question. His name is Dr. Michael Ratz.
Hey, Michael, how are you?
Good. Sorry I don't know everybody's name, but agree with the first speaker that everybody seems to kind of have different nomenclature, whether we're calling it accelerated hypertension, hypertension emergency, urgency. We do have standard protocols here. So when someone does check in, whether they are at 20 weeks, which bypasses us and goes to OB, unless it's trauma related, where they get a CMP, CBC, UA for proteinuria, and a MAG level. That way it gives us a little better direction if they are symptomatic, if they are having signs of end organ damage, where then we do get OB involved for their management as well.
Thank you very much. Thanks for ad hoc adding onto our speaker list.
Sure.
And Dr. Patel, do you want to talk about your facility?
So again, hypertension in the pediatric population is vastly different than in the adults. And so, and we're actually very cautious with using medications. So I think for us, when we consider this, as people walk in, they didn't mean to come to a pediatric hospital, or we found out. I think for the key in addressing for pediatric ERs is really to establish that consultative services, whether it is through the phone or telehealth, or if you're able to transfer them out, talking with our experts and asking for what are having a standard package of labs that we need to send, and then really the medications to utilize, first line, second line, to help us while we stabilize for transfer.
Great, thank you very much. And we are about at time, so I really want to thank our panelists for being with us today, as well as our additional speaker. And these are really great insights. I think it's going to help inform our project as we go forward. Opportunities from just having standard definitions for urgency, emergency, hypertensive, crisis, those things, that consultation process, defining what we should treat for pregnant patients or postpartum patients, and just education across the board. So again, thank you all for being here today. And we will have question and answers at the end after Ms. Tegas speaks with us. So please come back on in a little bit and we'll get some Q&A going.